afternoon. So we're going to administer a primary IV medication to Earl. Again. So before I even were to enter the patient's room, I would check the order, collect my supplies, perform my 7 checks on the order for the medication, and once again perform the 7 checks outside of his room. And then once I enter into the room, knock, hello Earl. I'm here to administer some IV medication for you. It looks like you're going to get IV vancomycin. You know what that is for? You're right. It's an antibiotic that you're going to be getting, IV. So, the patient does not have a currently established patent IV, then it will be necessary to start one, which you bring, I think, a start kit with you. Most of the time, if they have an IV that is not been established as patent at the moment, just in case that IV is no longer usable at the moment. So, first things first, Earl, do you have any allergies? Earl says no. I would check Earl's, asking for his name, date of birth, check it against his wristband. If he did have allergies, there should be a wristband stating that. But always ask and check the chart. I will perform my 7 checks again. The right patient, right drug, right time, right dose, right route. Reason, and there's one I forgot. Location. No. Well, it's 11 o'clock, and I have your vancomycin. It's being administered between 10 and noon, so it's 11. So it's a good time now to administer it. I see you don't have and I will not be actually puncturing this bag of IV fluids because I don't have anywhere to put it. So once that's done, I would start by opening my bag, checking the expiration date for clarity of the solution. If it's not meant to be cloudy, I don't think there are any that are like that really, except for I think just feeding and blood. So this is technically expired. It says expired October 19, but thankfully Earl doesn't really care. Check that we have the right drug. If it's going to be hung in an IV, we'll likely have a sticker on it from the pharmacy telling you what is in the bag. And then you once again double check that against the MAR as well. Prepare your IV tubing. So there should be a score line, I believe. There it is. So now that we have our IV tubing out, we will clean our hands. And I only have the 1 glove, so it's just going to be 1, but I would put on 2 pairs of gloves, especially to start the IV, if that's needed. And if I need to start an IV, I will take a quick look at Earl's, preferably lower on the hand, maybe just above the wrist, or just on the back surface for an IV site. If any of them look promising, before I apply the tourniquet, because especially for older people, that tourniquet can cause some significant pain. So I'm going to apply the tourniquet, which I have here once I've identified a site. Depending on the case, I would likely go with a 20 gauge IV, unless it were a situation where they needed a large bore IV, such as a trauma, where lots of fluid and whatnot needs to be infused quickly. I would then apply the tourniquet. And find my site. Once I have my site, and I would have a 10 milliliter saline flush that I would have attached to a J-loop. I would make sure that J-loop is primed and nearby. So we have that. I would clean the site. So I would take this, clean the site, allow for it to air dry without blowing on it. And then once we're ready with the tourniquet on, I would take the IV, insert until I see a flash, insert a little farther, advance the catheter, remove the needle, remove the tourniquet, take my J-loop, attach it to the hub of the catheter, and then test for patency, extravasation, if I blew the line or not, by inserting that 10 mLs of saline into the patient. Once that's done, I've determined it's patent. I will attach a securing device to the IV to make sure that it stays in place, it doesn't get pulled out too easily. I would then take, once that is done, and we have the J-loop secured to our patient, I would remove, and keeping the end of this sterile from the packaging, remove this, and then I would take this, plunge it in there, twisting until we had opened up through the hole, and then I would allow I'd fill this chamber approximately a third to half, flip the bag over, and allow it to drain through the tubing until it reaches the end, at which point I would then clamp off my tubing, take it, I'd scrub the hub of the J-loop just in case for 10 to 15 seconds with friction. I would remove this cap, take this and attach it to the J-loop, and then using, for a gravity only feed and the known drip rate of this package, which is 10, I'd be able to calculate how many drips per minute I would want coming out of that chamber into the flow to go into the IV, if it had to be regulated like that. Or if it was just a bolus, I would likely just open it wide up and let it flow in, checking the site regularly for things like extravasation, phlebitis. Extravasation you'd see as this cold, not hard really, but stiff, raised area, and it's possible there could be some pain with that, depending on, especially depends on what is actually flowing in, which could lead to like tissue necrosis, various other knots. So, or with phlebitis, you'd see it, it'd be localized, kind of red. They would describe it as painful, be warm to the touch, and if that were to happen, it's indicative that the IV needs to be removed and replaced and placed somewhere else if they need to continue receiving IV treatment on them. And like I said, regularly check that site, make sure there's no bleeding, no hematomas, extravasation, phlebitis, and just watch for the patient for anything that might arise, such as an allergic reaction to what they're receiving, or something that maybe not the medication, but the way the medication's formulated, they might end up with an allergic reaction. think that's it.